Good evening, everyone, and welcome to over 600 of you to the Royal College of Surgeons in Edinburgh and our latest dental webinar, reviewing recent advice for dentists on getting back to work and do you feel safe in their hands? I'm Richard Cure. I'm convener of dental education at the college, and on our panel this evening we have Phil Tainer, who is the Dean-elect of the college, Nadia Al-Ani, who is a GDP in Wakefield and an FD trainer, Jeremy Hayes, who is a consultant in restorative dentistry and works in specialist endodontic practice, and Linda Cruz, who is head of indemnity at the BDA and a GDP. So Phil, can I hand over to you, please?
Thank you, Richard. Welcome, everybody. I just would like to go through what we're going to consider this evening and where we are so people understand what we're trying to do. Really, we want to understand if you believe the advice you've been given on returning to practice is detailed enough for your practice. If we do make some changes, are they going to be the new level of universal precautions? Do you feel the PPE advice that you've been given is enough to keep your patients and staff safe? And we will gather some evidence because we're going to have some questions during this evening's conference, and we want to know about your returning to work, and we're going to lobby on your behalf. And I can just give you a little update on that, as we have had already some considerable newspaper coverage on our support for our members and fellows. We have also been lobbying in Parliament, and we have some questions that are being put to Parliament from friendly MPs on our behalf to lobby for you as members and fellows of the Royal College of Surgeons of Edinburgh. More specifically, we want to know what levels of PPE you think are safe. We want to know what the safe downtime is for aerosol generating procedures after the patient's left, and I think that's going to be very different for different practices. And what do you think you need to know for you to feel safe? So what will happen is you'll see a screen like this. You won't be able to answer the yes and no bit at the moment until I ask for that. And I think we want to start by asking a very simple question. Are you absolutely clear what is and isn't an AGP? So maybe we could open the poll for that one, and then we'll have a little discussion afterwards. You should be able to see the poll on your screen if you can answer yes or no to that, and then in a little while we will be able to look at the results from that. I think we're giving about 20 seconds, I think, for people to answer. Okay, so 59% of you are clear and 41% are not clear. And I think the only place where really we've got some clarity is from the CDO England document, which was the standard operating procedure transition to recovery. On page 19, it actually lists non-AGP procedures. So maybe the panel could talk through what they feel is or isn't a non-AGP procedure in dentistry. Len, do you want to start? You'll need to remember to unmute.
Yeah, I mean, I think the list is quite clear. I suppose the challenge for people is actually understanding. It seems almost binary in nature, this idea of AGP and non-AGP. And those of you who are familiar with the FGDP guidance that came out last week, it throws in a different sort of concept, which is aerosol generating exposure, which suggests that there is a gradient of risk. So it's not as black and white as the guidance says. So, but I think a good starting point is the list from the CDO, from the standard operating procedure. So examinations, interestingly, and Richard might pick it up if he wants to, but orthodontics was described as non-AGP. So all the things, radiographs, routine sort of care without using aerosol. So I think the non-AGPs are quite clear. There is a little bit of contention earlier on about orthodontics. The BOS had a view. They've subsequently issued other guidance in the last day or so, and I think everybody's happy with the AGPs. The issue, I suppose, really is it's the non-AGP. The issue really is the AGPs, and I think that's where the debate lies.
Could expand on that a little bit, because we did talk about earlier on about examinations and that being a non-AGP, but I suppose the question we've got, and maybe we could ask Nadia about this, because this is more pertinent to all of you in general practice, is the use of a 3-in-1 syringe when you're actually doing an examination. How do we manage to do an examination without a 3-in-1?
So we've managed it. Well, we've taken it in the sense that you can use the 3-in-1 syringe if you're using the air, and you can use the 3-in-1 syringe if you're using the water, but you can't use the air and the water together, because by putting the air with the water, that's then generating the aerosol. So a 3-in-1 without the air and water, without the air and water together, can be used for an examination. However, to try and limit the use, so still to try to do things as much as possible without it. We are aware that in some countries it's banned to use it altogether. But the guidance isn't consistent across the board, so you kind of need to work out how you work and find a way that works best for you, and also need to be justified in why you're doing something, and put some thought into it behind it.
You're muted, Phil.
Thank you. I was being good. I think if I ask the question to both Len and to Nadia about this, do you feel comfortable with that as advice?
Yes, I do. I feel comfortable with that advice. It's the idea of aerosolization that's the issue, and the blanket suggestion 3-in-1 shouldn't be used really doesn't stand up to much credibility. So I think it's if you're doing for an examination, obviously you're not going to have a rubber dam, obviously you're not going to have high volume suction, all the things we know are mitigating factors. So obviously, but in order to examine the teeth, you need to dry the tooth. You would probably not be using the water and air unless you're probably doing a restorative procedure. So drying the teeth with air, doing an examination is probably pretty routine. And the only time you're probably using the 3-in-1, I'd imagine, is when you're doing a restorative procedure. You're washing a tooth, you're washing edge of a tooth. So that would be part of probably an AGP potentially. So I'm happy with that.
Yeah. I agree with Len. I mean, we've started back with, we're doing non-AGP procedures, but we're trying to do anything urgent that is a non-AGP. So sometimes that might be, for example, if somebody's fractured a cusp or there's a sharp edge, temporizing it with something maybe simple like GIC. So we may have to wash or we may have to dry. So yes, normally it would be part of routine restorative. However, we're trying to use it in this instance and be careful when we're using it, but it does need to be used.
I think I will ask Richard the question, because the Orthodontic Society has very much changed its mind over the last week. The website the week before last was that everything in orthodontics was an AGP, and now everything isn't an AGP. So how do you feel about a sort of return to work from an orthodontic perspective?
Yes, thanks, Phil. I think that I think the BOS has been appropriate in terms of the advice that they've given, and have probably acted on the side of caution, which I think is appropriate for all of the orthodontic team. And certainly, I think probably the majority of our treatments are non-AGP. Where we may generate aerosols is depending on the techniques that are used for bonding and debonding fixed appliances. And again, I think certain techniques will, if not eliminate those completely, will keep them to the very, very minimum. And in some circumstances, not at all. I think the main one is where there may be some composite material or adhesive material of whatever sort that's left on a tooth that needs to be removed. And then obviously most people would use a slow handpiece and can use appropriate suction with that.
And Jeremy, not for you to feel left out, have you a comment as well?
Well, I haven't got a comment on what's happening in England.
Well, tell us about Wales.
Yeah, I think, well, just to go back to, I mean, the list of what is and what isn't is presented, as Len says, as a binary matter. But it probably, the realities of clinical dentistry are that you might be in the middle of doing something and the situation changes. So I can see Nadia's point about using either water or using air. Clearly, if you use both together, you are at risk of certainly splatter. We've had some discussions in our centre about adjusting dentures that have been in the mouth, using a motor to remove acrylic, for instance, and the risk associated with that. My world is mostly endo, and I've got rubber dam on, so once that's on, I'm much more relaxed about contamination of the aerosol. We've got high volume suction, and that's, you know, that's my insight into the current situation, really. Okay, but it's not as straightforward as this isn't, because you'll be in the middle of something and the situation will change. I've taken intraoral radiographs because I needed an intraoral radiograph, or at least I felt I did, as part of the diagnostic process. And if the patient starts coughing and gagging in the middle of that, then potentially that has implications. Likewise, if you took an impression and the patient was fine throughout, that seems pretty straightforward. But if they start retching and gagging, then we may be exposing the area to more risk.
Okay, thank you. We'll move on to the next question, which is, do you think you need any extra PPE to that you were wearing before the pandemic? I think we all as dentists think that we were way ahead of the game as far as cross-infection control was concerned prior to the pandemic. And I think even in the hospitals, I can tell you that the rest of medicine are looking across at dentistry in admiration at the things that we were already doing before the pandemic. But there have been now additional things. So I think if we can put the poll on and see whether people think they feel they need any more PPE than they were wearing prior to the pandemic. Okay, so that's a resounding yes, and probably not a big surprise, but I think the important bit about this is that we don't get into a state of hysteria. So the issue is more around where we get to a sensible measure of extra precautions compared to just being something where we're buying something for an unnecessary part of the procedures. So if that's the case, then we need to start to look a little bit about what we think we should be wearing. And I'm going to go into a little bit more detail about that. One of the things that people have been talking about is whether all your staff should be wearing scrub type uniforms for work. So this means obviously that they're coming to work, they're getting completely changed at work into some sort of work uniform. So do you want to do the poll for that one, and then perhaps we could talk about that one? So, okay, so that's a resounding yes. And I think the question there, and I think perhaps we could talk about this a little bit, is facilities. It's not always that easy in a small dental practice for someone to have changing facilities when people come to work. And maybe there's a little bit to discuss around management of that, segregation between male and female changing rooms, how you're going to do that. Are people having to change in the toilets because that's the only place they can change? How do they feel around that for the smaller practice? Nadia, do you want to? I know yours is a larger practice, but maybe you...
I've The practice I'm in now, that I've been in for most of my practicing career, is a quite large practice. And when I started there in 2010, we had moved to a purpose-built facility. So we have separate change rooms for men and women. And we also have always changed when we arrived at work. We previously had a system whereby our uniforms were laundered and ironed in the practice for us as well. However, now we are doing them at home. But we have always changed full clothes and shoes. And we had...
So why has that changed, Nadia? Why have you changed that?
Cost and cleaning and finding somebody that was a cleaner that was happy to do it, because at the end of the day, it took a very long time to iron and hang them all out. And
right, okay, so it's just
9 years.
Yeah, okay, yeah.
But that was how it always ran, and we always changed shoes. So even on a lunchtime to go out, pre-COVID, we would change shoes. So from my point of view, that's always been the case. Now, I have also worked in other practices that didn't have changing facilities and were much more relaxed in uniform, where people would come in uniform and go home in uniform. I think, however, the fact that I'd been in the practice I'm at, I was so influenced. And previously, before qualifying, I had worked as a dental nurse. And we'd have practices where we changed there and changed shoes. So I think that was always in my habit to do that. And I think that's just how dentistry is generally compared with hospitals. I don't think hospitals, unless you're in theatre, have quite as much cross-infection measures in place as we do in practice. So I think we just adopted that and we've run with it. So we haven't really changed. Our reception staff also changed shoes and clothing, but they're not in scrubs, they're in reception wear.
Okay.
But they're changing at the practice.
Well, that sounds like exemplary levels. Jeremy, is that something that you see in the hospital where you work? Do you see people keeping to the rules?
I mean, this is probably the most fundamental change for me, because my day job, as it were, in the hospital dental services, I wouldn't necessarily have a treatment session, treatment every session. So I might have a new patient clinic or a review clinic, and then treatment would be a separate thing. So I think not uncommon in terms of my colleagues, I would do a new patient clinic in the clothes I came to work in, and then I change for a treatment session. So the big change for me is that we've done pretty much what Nadia was outlining, is that I change when I get to work into scrubs. I'm in scrubs during the day for the AGP procedures. I shower in work, change back into my clothes and come home, and we launder the scrubs in the appropriate manner. So it's been a big change for me. I'll offer an observation that I think it's probably less of a change for the dental nurses, because they're more used to coming. They've always worn scrubs, so I think it's less of a change for them probably.
Yeah, I think.
Sorry, I've just got a note from my practice principal who sent me a message about the reason why we stopped washing and laundering was that the new infection control of the deanery told us that we couldn't anymore. So I was
that is interesting. So I looked up the latest information on the government website, and they're talking about washing at 65 degrees plus. And I was assured yesterday at my staff meeting at the London Hospital that that's not possible with a normal washer. So it seems like there may be some different advice coming out from the government again on what is and what isn't sensible as far as washing is concerned. Because they were saying that we should take home, because actually at the London we don't have facilities to wash our scrubs, so we would have to take them home. You take them home in a pillowcase in a plastic bag, and then you wash them. And I presume that maybe is what's happening now with yours, Nadia. But it does seem a little bit strange. But we also need to remember that COVID, if that's what we're worrying about, actually is cleared with just washing your hands in cold water. So having something at really high temperature is maybe not for anything to do with COVID. It's more to do with any of the other possible infections. And we're probably looking at Hep A, B, C, D, wherever we're up to with that now, rather than worrying about COVID from that point of view, I think. Len?
My understanding is also that it's not actually the temperature, it's actually it's the dilution effect of the detergent. So if you put it into the washing machine, you don't stuff it full with a whole lot of other stuff. It could be 2 or 3 items in there. It's actually the dilution effect. So, and some of the materials that you're using, the polycottons, may actually not be allowed to run at 60 degrees. So
that's right. They were destroyed at some of the high temperatures.
So with 30, 40 degrees, I think it's more to do with the detergent and the dilution effect of cleaning it. So I don't think people need to worry too much. And as you say, the toolkit, our toolkit, the BDA says 60 degrees, but I think you just need to be aware that if it isn't 60, if your temperature, if you're going to destroy your uniform, well, don't do it.
Yeah, and I think what you said, Nadia, is actually true about the hospitals, that we do have more problems with our DCTs going out for their pasties at lunchtime in their uniforms than perhaps you do in practice. So there is, I think the hospitals need to learn from general practice quite a bit from that point of view. So if we move on and we talk about whether you need long sleeve surgical gowns. My personal view on this, and this is actually something that I've always been concerned about, but I did find some literature on it. There's an article by Wiener in 2015, which was called Dissemination of Aerosol and Splatter During Ultrasonic Scaling. And they showed the operator's dominant arm receives a high contamination, as does the assistant's left arm, and that's for a right-handed operator, is obviously the other way around. Now, I've just said 2 minutes ago that if you wash your skin with cold water and soap, then it gets rid of the COVID. But is it more than COVID here? So we're back again to what should be a universal procedure that we're going through. And are we then saying now that actually a long sleeve surgical gown should be something that we should think about? And if we take that from the other extreme, it's, Jeremy, are you going to be wearing that during your non-AGP procedures as well? I don't know who would like to start on that one. Anybody?
Okay, well, I mean, this is again new. So, I mean, the summary data from my experience is that the dentistry itself has changed very little. In surgery, access, cavity preparation, and sort of initial management is the same as it always has been. But the things that have changed are me getting into work, getting ready for work, and what I'm wearing to do it. I'm not entirely sure whether we do need to wear long-sleeved gowns. I am wearing a long-sleeved gown because that's what the instructions are. And whilst we're in the middle of this and trying to deal with it, I'm very happy to go along with it. I think we'll need a lot more time after this to look back before we're able to be definitive either way. I was very happy with being bare below the elbow, and we washed our hands up to the elbow as part of all the procedures. Again, and I don't want to keep harping back to rubber dam, but the people I've been meeting, we've had rubber dam placed fairly briskly, and then my comfort blanket, if you like, is that the aerosol isn't infected, and I'm just carrying on as I always have. If someone says that we don't need long sleeve gowns, I'd be quite relaxed about that.
Yeah, I mean,
Jeremy, I think sorry, Len, do you want to?
Carry on.
I think you had a really important point when you said nothing much has changed in terms of over the last so many years in terms of what we're doing. And Phil's point about we're washing our arms and that's getting rid of COVID and also getting rid of so much else. One thing that has changed is litigation and how that impacts the dental practice and why we do a lot of things that we do. At the end of the day, you know, who is going to trace it back if there is transmission, and how will that be proven? And I think it's the type of culture that we're in now that maybe dictates the type of PPE that we're wearing as opposed to the actual threat of a microorganism.
I mean, I think it's a good point, Nadia, but I think the issues that we probably set the bar quite high going into this, going back to work. And because of precautionary principle, there's a paucity of evidence that's out there specifically in relation to dental aerosols. We have lots of other relationships in other hospitals and trusts and other environments, but not necessarily in dental aerosols. So we don't actually know how pathogenic those aerosols are. We don't know if there's dead or live viruses in those particular aerosols. So we've gone back to work with a paucity of evidence, but expecting that we just need to be cautious. So but if you look at the basic concepts, the only way this gets transmitted essentially is through your eyes, your nose, and your mouth. It's not through skin. So having the idea so if we look at this logically, we look at things like aprons and gowns and stuff like that. If it's not going to be transmitted through your skin, you don't need to worry about it. I'd be, me personally, I'm not going to be wearing a gown for AGPs or non-AGPs, because actually, as far as I'm concerned, I will go in there, wash my hands, wash up to my elbows, and clean my skin down. And that's again, that's a personal view. You have to decide. And this comes down to the primacy of guidance. We've been hit by a plethora of guidance over the last week and a half. Everybody's, we've got the Royal College of Surgeons, we've got FGDP, we've got the CDOs of 4 different countries, we've got regional guidance as well, all of which everybody's clamoring for your attention. And you kind of get whiplash looking from one thing to another, trying to work out what's correct. The bottom line is, as far as, it's a good point you make, Nadia, the bottom line is it's your SOP, your standing operating procedure, becomes the most important document. And people were never really bothered about SOPs. They are becoming quite relevant. So having spoken to a number of solicitors in the last few days, the idea simply is, there is guidance. As long as there's national guidance, you pick the national guidance that suits you, you put into your SOP, and that becomes your standard operating procedure. And your standard operating procedure is unique to you. There's no problem about nicking somebody else's and starting from scratch, but nicking somebody else's, but then adapting it to your practice. And you will find, probably, Nadia, yourself, you've already gone back to work. I've already gone back to work. We're already changing things virtually daily. And so we're on to version 4 of our SOP. We've only been in practice for 3 days. But what you do is, you have your SOP, you have it dated, versioned, version 1, version 2, version 3. You keep hold of it. Because in about a year, 2 years' time, if any litigation arrives, as it's likely to do in a year's time, not going to be happening in a week or 2 weeks' time, a year's time, 2 years' time, we've forgotten what we're doing, absolutely forgotten. So we don't even know what was happening at the time. You go back to your SOP and say, well, the chance of me giving you COVID, either you as a staff member or you as a patient, is pretty limited because we have this particular SOP in progress. And that SOP will be varying from surgery to surgery, because if we talk about fallow times, we talk about your fallow time might be different in surgery 2, surgery 3, might be different in surgery 5 because you've got air conditioning, got a window open or whatever. So your SOP will be unique to you. And all you have to do is demonstrate that if you've got a certain particular procedure, you've chosen a particular item from the FGDP guidance or from the BDA toolkit or from the SOP, you've used it, you've adapted it, why you've adapted it, the reason you've adapted it, and why you've adopted it, and why you've rejected something else. And so surgical gowns will be part of, it might be an operating procedure. So actually, you know what? We'll definitely use it for AGPs, but we're definitely not going to use it for non-AGPs or whatever. And as long as you've got that recorded and the reasons for doing it, you'll be fine. You'll be protected from litigation, and your defense organizations and indeed your insurers for your practice, for employers' liability and public liability, will be able to protect you and defend you. So be reassured, as long as you've got a rationale for using it, because this is, in the end, it's just guidance. It is just guidance. It is not the law.
So can I just to expand on that, because I think this is very important for everybody, and that's good news that you've given us there. But I think one of the questions that people probably will concern themselves about is whether, if the CQC get onto the back of this, and the CQC tend to follow whatever the CDOs said blindly, and I wonder whether you feel that then there may become some issues. It doesn't kind of matter. You could write an SOP that I'm not going to be bothered about cross-infection at all, but yeah, that wouldn't.
Yeah, I'd CQC, I actually have no problems with CQC whatsoever, because CQC are actually quite sensible people. John Mill's a very sensible person. It's actually quite a sensible organization. They'll say, all we expect you to do is have appropriate risk assessments and protocols, well led, the appropriate amount of materials in order to control infection control. You have the right appropriate procedure, and you follow them.
Okay.
And as far as CQC are concerned, you've got a process, you've got a protocol, you've got a rationale for using it, even if it's different from anybody else's. That's perfectly fine. Well, you don't make it up, but you use the guidance that's currently out there. I'm pretty confident, certainly from an indemnity perspective, certainly BDA indemnity perspective, we'd have no problems with that issue.
Okay, well, I think that's a good time for us to do the poll now, because I think we had a good discussion about that one beforehand. So maybe we could put the poll up. Okay, well, that's getting a little bit closer, isn't it? But there are a lot of people there saying that they're happy not to be wearing long sleeve gowns, which is interesting. And I think there's obviously a lot more discussion needs to happen outside this organisation to be starting to talk about that, because there is a big cost element here. If I can tell you that we've had some discussions in London with the commissioners, NHS England, and they have a calculation that if all of the London practices went back to work and were seeing the same number of patients they were seeing before the COVID epidemic, it would cost them £1 million a day to provide PPE. Now, that, if you extrapolate that across the country, is amazing. But if you start to look at the numbers that people are really managing to see a day, I've sort of calculated that will be £65 million a year for London alone, which is an awful lot of money.
Well,
So
I think if I might chip in on this,
yeah.
We've all been working for years with short sleeves.
Yeah.
And to my knowledge, there's no evidence of us actually contracting Hep B, C, D, or whatever. And as Len has said, the transmission is not through the skin. So almost it appears if it is more difficult to wash clothing, the simpler the clothing, the better.
Yeah. And actually, that was something that somebody's asked a question about as well, about that. And I think the next question kind of deals with that a little bit. So although the way that I've written the question, sorry, it doesn't want to move on for some reason. That's it. And I've written on here, if there's no obvious blood or markings, do you think it's safe to wear the gown? If we ignore gown, and we'll now call that, we'll talk about this question as clothing. Because the problem is, of course, that if you're wearing a scrub top, you still can get things on your scrub top. We've all worked, and you turn around and you end up with something down the front of your top. How easy is that going to be for people to manage in practice? The next questions are going to be talking about whether we have the plastic apron. So if we can leave plastic aprons out for the minute, but it's a matter of what you feel, whether you've got this work uniform, and then if you had the gowns were a coverall to protect your uniform. So there's a bit of a difference between when we've gone a bit beyond short arms and long arms there, but we're talking about a different sort of covering. That stunned everybody. Jeremy, I'm going to put you on the.
Yeah, okay. So, well, I mean, again, we've sort of, this is in context of COVID, it's a respiratory virus.
Sure.
And the arm coverage, or the protection of the scrub top, is irrelevant in terms of that direct transmission. So then the concern is that the scrub top on your forearms, your dominant hand, are contaminated, and then we are adopting the hand washing regime that we've used routinely to deal with and mitigate for bloodborne viruses and that. So as I say, my horizons are slightly further than the next 6 months. I don't think we'll know much about what we've done for maybe 3 or 4 years. But I'm happy to follow the precautionary principle at the moment and wear the PPE as recommended. But I think it's slightly diverting us from the main concern, which is social distancing, which is how we're going to manage it and how we are bringing the numbers down. It's the poor people that contracted this virus didn't contract it in healthcare particularly until they went into hospitals with other things. They came back from skiing holidays, they came back from winter sun holidays, and it wasn't about having their arms covered or not. It wasn't necessarily about being at the dentist unless it was about being in the same place, the same waiting area as someone else.
Yeah. Nadia, what's your opinion on this?
I think it's a difficult question to answer, and I think I don't think I have an answer. In the sense that when you for the sense that if you take the word gown out of the question, it then becomes our uniform, as you said.
Yes.
Which is up until now we've worn it for the full session or for the full day. And we haven't thought twice about that, and we felt that was actually very effective, because then at the end of the day we change out to the uniform and we go home. And then, like Jeremy said, it's a respiratory virus, and also it's transmitted through breathing in and inhaling. However, some of the guidance I was reading was if you've got a shielded patient, that you should be in something clean for that patient. Well, what if you are seeing 5 shielded patients in a row or 10 shielded patients? How feasible is it then in general practice to change the full scrubs outfit? And then, I've just come in and said, oh yes, we changed shoes. Well, are we going to change shoes for every patient? Where does it stop? And then why are we doing this? And then what is the evidence to say that we should be doing this? So I don't have an answer. And I think I probably speak for a lot of GDPs like me who probably don't have an answer and think, okay, what's the most pragmatic way that we can approach this, and how can we be sensible about it? Because we're not going to be, well, at this stage, we're not going to have evidence to say this is exactly what we should be doing and why.
So I think that one of the questions that's been asked by the audience is around what would happen if you sneeze and you put your arm up, as we're told we have to do. Obviously, you could go and wash your arms again. That's not a big problem. But I think where the balance lies is a little bit in the fact that we know that the virus is actually spread in saliva. What we also know is that actually the level of viral load in an infected person is higher in the morning than it is later in the day. So whether your concern now changes a little bit in this, and I think Len touched on it before, is what is an aerosol, and we know what droplets are, and we know there's a lot of evidence around droplets, and we can be pretty clear about a safety zone, if you like, around droplets. What we don't really know is how to measure aerosols, and we don't even know whether the aerosol's an infected aerosol or not. So there becomes a bit of a bigger issue around that. Now, the reason I'm saying that is if you're wearing just a scrub top now, which is what this question's now sort of morphed into, then are you concerned that if you don't change your scrub top between each patient, you are potentially creating a format where the virus is embedded, if you like, for the next patient? Now, the reality is whether that's going to jump off this piece of cloth onto the patient is pretty unlikely, but I think there has to be maybe has to be some thought about that. Len, you're smiling, so I'm going to give you the hospital pass.
Yeah, I mean, I think I've always done it. We've always worn scrubs. I think I'd be in Jeremy's camp now, and actually think very much about the stuff that you come to work in. You put to one side, you put your scrubs on, and you'll take your scrubs off, and you'll go home in your clothes that you came back in again, and that's the thing I definitely will be doing differently. It'll be the same with shoes, the whole lot basically. So there'll be stuff that stays in the practice or gets washed in the practice or gets washed back home, and they're separate. So I think with Jared, that would be things that I definitely would do. But in between patients, I personally would wear it for the whole day probably, unless, as you say, there was blood on it, or alginate or anything else on it.
The other thing I think we need to think about, even if it's a non-AGP, we're doing denture work, you have a lot of patients when doing impressions or denture work that are coughing or gagging. And at the end of the day, take a step back from before COVID, we're a caring profession. How many older patients come in and they reach out for your hand, or they lean forward, or they may hold your arm to sit down, or you're sat there and they may reach up to touch your arm behind you just to tell you something. You know, your clothes are being in contact, your patients are in front of you, you will get splatter on you. That is the nature of the work that we do, and we also need to bear that in mind.
So I think what I'm saying then is that not an argument for us to wear something over the top of the scrubs? Because between each patient then, I mean, what I'm saying is, and what this is it is a big conversation now, because this is changing the universal precautions that we normally use. Yeah. And maybe we've got away with it okay in the past, and that might be okay, and I'm not saying it's not, but I'm being the devil's advocate and saying maybe actually we weren't quite good enough, we were so much better than everybody else, but that little step is the step that makes us ready for what I will call COVID-21, which obviously hasn't started yet, but what we don't know is what's around the corner. And is it worth us at this stage, because we've got the momentum to say, actually, we need to just do that extra bit, which will give us the protection against this more dangerous virus or bloodborne disease that we've just not got at the moment?
Well, I would suggest it depends on what we're doing and what the environment is as well. And procedures will be different in endodontics to restorative to surgical to orthodontics.
Sure.
And I think the practicality of it is, to be blunt, if that is what is becoming the norm or the routine, very few practices will be able to afford to do that.
Okay, and if I just do two questions quickly from the audience. One talks about using an alcohol spray on your scrub after each patient. Do you think that would be effective?
Not sure. I wouldn't. No sort of evidence about that at all. Not sure. There's.
No, I can't imagine that it would penetrate sufficiently to be. I'd be concerned about that. And the other one was, if your scrubs are contaminated, are you going to contaminate your face when you remove your top? Which is a good point with donning and doffing, because we've made a big deal about donning and doffing everywhere, haven't we now? So
yeah, well, I think there is a risk. And that's why you carry on cleaning after removing the work clothes. So, I mean, again, it's not a cop-out. I hope it's not, doesn't have a cop-out, but my clinical practice is based on seeing very few people a session. So the multiplier for enhanced PPE is not quite as impactful. However, at the end of the session, having seen relatively few patients, the potentially contaminated scrubs are placed in the cloth bag, and I'm getting in the shower before I get into my clothes for going home, and I'm taking it very seriously.
Okay, so should we do the poll for that one now?
You're only on question 5 here, Phil. You do.
I know I'm going to get a move on. Yeah. So that's 50-50, isn't it? Okay. All right. Okay. So let's move on to the next one. And my favourite subject of plastic aprons. I'll open the batting by saying that I think I don't really want to look like the fishmonger wearing these. I have no idea what these are for at all, but that's my view on this. If we were wearing water repellent gowns, then these are completely redundant. But I'm not quite sure what they are, especially if you go back to that Vena article, which showed that the majority of the splash was actually on your face, your eyes, around the side of your face here, and on your arms. So not quite sure what I'm protecting, really. Can we run this one?
Yeah, I mean, I think that I think what the point is basically is obviously we're all very familiar with that the table from PHE Health Protection Scotland, that green table, and it says disposal plastic apron tick for a non-AGP essentially, which is bizarre because so if you're not creating an aerosol, you're not creating anything else. As you say, what is it covering? It's just covering. To your point, Phil, it's covering your overall, but it's not covering anything else. So as you say, I'm not inclined to.
They are cheap. They are cheap. So one of the people who are listening in have mentioned that, and it is true that they are cheap as chips. But it's whether they're doing anything at all. Is the thing. Nadia, you're.
I'm just laughing because I'm with you, Phil. I don't see the point. I don't understand what they're going to do, really.
No. I think they're quite good when you're adjusting a denture because you don't get the powder from the denture down your front. But then but then I usually get the plastic apron in the denture as well, so that's usually made more of a mess of it.
It's the kind of thing we maybe would have used for endo, but we'd still end up with hypochlorite on our scrubs. So.
And they'd probably be better on the patient, so you don't get it on their Armani suit.
Yeah.
Jeremy, you're the master of hypochlorite.
Thank you. Yeah, well, let's not get into. I mean, if you're okay, you could drop the hypochlorite on you, but I think if we're using the hypochlorite properly, then it should be confined very closely to the access cavity and the tooth in question. So,
Okay, so let's go for the vote with this one. Okay. Well, that seems a pretty resounding no. So they are not winning, are they? Then the next slide actually is on a similar vein, but this is something that's been recommended. So we'll just go straight to the vote. We'll not have a discussion about this one. I suspect the answer is going to be no. Or have I influenced the judges? Perhaps you're not allowed to do that. I'll get thrown off the BBC. Yeah, the same again. So plastic aprons aren't doing well, are they really? Okay. Now, this one is back to plastic aprons, but it is to do with what I think, Len, you mentioned before. It's kind of like, would you wear it if you were going to wear a gown for a whole session? So if you're not going to change your gown between each patient, then are you then going to think about wearing a plastic apron because it might just protect the front of your gown from marking? If we very quickly just run round whether we think there's an advantage for that one. I'm trying to catch up a little bit because we're getting behind on time if we're not careful.
For me, yeah, for me, it just goes back to, if it's slightly logical, if you're going to wear the gown, if you're going to wear your scrubs, then you probably wouldn't wear the gown, and therefore you wouldn't wear the plastic apron. So, I suppose it starts from what you're going to wear originally. Yeah.
Nadia, is that the same for you, I think?
Yeah.
Yeah. Jeremy, are you presumably pretty well? Should we do the poll for that one, and then we're getting on to the important bits with the visors? This will be interesting to see whether people have changed their view on this one a little bit. Okay. Yeah, that's interesting, isn't it? That's people can see that there's an issue here with potentially not contaminating the front of your gown. That's interesting. Okay, so the next one is definitely about visors. So there's a lot of evidence here that the big deal around the splatter is around your face, particularly your eyes. We obviously are worried about what goes in our mouths and up our noses, but we will come to that in a little bit more detail. There's quite a lot of work, and it did show there are 3 decent articles: Watanabe, there's another one by the same one but that you've had before, Vina, and one that's an unpronounceable name, which I will have a go at, is Nejadidanash. And there's contamination of different areas of the dentist's face with significantly difference. The areas around the nose and the inner corner of the eyes were the most contaminated areas. The zygoma was the least contaminated area, and contaminated areas during periodontal treatments were significantly more than for prosthetic treatments, which is not a big surprise. And there was no significant difference between contamination on the left and the right-hand side of the face. So visors are pretty new to people in the majority. I know that people have been wearing visors, and it certainly at the dental hospital, I would say our nurses wore visors and dentists didn't wear visors. But I know there are issues around visors and loupes, and I know Jeremy will have something to say about visors and his precious microscope. So maybe we'll leave that just to the end and warm up with Len and see what he thinks about wearing visors. And I know you've had an issue with loupes today, so you maybe want to recount.
Yeah. So it's the same thing. I mean, I think visors are something we've, as you say, the nurses wear them. A lot of the staff wear them. I've never worn them. I think and that's something certainly I'll be looking to do. But it's again, I have oroscopic loupes with zooms, and actually it's going to be quite difficult to wear. So we're just going to have to use the existing visors, cut holes in them, and use it in that way. I think the important thing is that those visors need to have a seal around the forehead, because the aerosol is going to creep down. If the aerosol's in the air, it's going to come straight down. It's going to come onto your eyes. So if you don't have goggles, if you don't have glasses, that the visor has to cover over your face, and it's also going to cover your forehead, so you get that seal. So it's important that the visor is the visor, but also glasses. So if you're not going to wear the glasses, the visor's got to be properly fitting.
Yeah. Okay, Nadia, have you started to wear a visor or?
So I've been on triage, so I haven't been wearing.
Okay, yeah.
I haven't needed it for that. But I'm normally a loupes wearer. I wear loupes for everything. So it will change how I work, because I'm quite used to working with loupes. However, I've been having a look, and I think you can find visors that fit round to the loupes that you have. I haven't tried it yet, but one of our associates has, and he seems to be quite happy with it. So
yes, I've had the advertisement for that as well. So
after reviewing the evidence, I definitely would want to have a visor on. I just need to find a new way of working with it with loupes on.
Okay, and Jeremy, and you can recount your issues around visors and endodontics.
Yeah, thanks. Well, I've never worn a visor because I've always used a microscope. So the last couple of years I've had to wear glasses as well. So I've spent the last, since we started in the urgent centres opening teeth without the comfort of my microscope, and it's been quite a challenge. I've worn the visor, and there's no question that the visor's in the way, and I can't wait to get rid of the visor. So I note that several of the companies now have made visors for the scopes.
Yeah. And
I'm hoping that we're going to get a version of that sooner rather than later.
Okay. So perhaps we could open the poll on this one and see what people think. Okay. Wow. Okay. That's pretty clear, isn't it? Okay. Now the next question is similar, but it's whether you feel that you need to wear it only for AGP procedures. So we'll just do a poll straight away on that one, I think. Okay. All right. So that's interesting. So that's changed slightly. But so people are thinking that they might want to wear their visor when they're doing non-AGP procedures effectively from that. So that's quite interesting. I suppose there becomes a level with any of this PPE. It's a bit like when we first started to wear gloves, that it was uncomfortable at first, but if you get used to wearing it, then you just wear it whatever it is. It doesn't matter whether it's AGP or non-AGP. And that will be probably the same thing that's going to happen with visors in the end. I think that it looks as though that's the way that things might be heading. Now, there was a question from the audience, and actually this is really the next question, because they were concerned about wiping the visors and whether you need to have the type of visor where you can actually throw away the face shield between patients, or whether you're happy to just wipe the visor down between patients with something like a Clinell wipe or something. So just very quickly, Jeremy, would you be worried about wiping a visor? Do you think that's a big deal?
I think depending on the design of the visor, the simpler the design in terms of nooks and crannies, then if you can get to it, you can wipe it down, and it's the same as any hard surface. And in that, the slightly more robust visor better than the flimsier visor. But of course, the flimsier visor is the disposable version. So our protocol requires that I leave the visor in the surgery. We've not had an issue with PPE. We've got plenty of visors, and so I've got a couple on the go. But it's a smooth surface, and it should be very amenable to chemical disinfection.
Okay, and we'll just ask the other panelists as well.
I would agree with Jeremy. I would say the same thing.
Yeah. Okay.
I'd agree. It's probably not wiping; it's actually cleaning, as opposed to just a quick wipe. So I think a bit more than a wipe.
Okay. Yes. Okay. So I think, should we just have a quick vote on that one, please? Okay. Yeah, so that's pretty clear, isn't it? That's good. Okay. So our next question, if my button isn't working again, sorry, it's having a, that's it, is where we're getting to the nitty gritty again here, is about whether you think you need to wear an FFP3 mask for all your AGP procedures. Can we just have a sort of yes and no from people? Len, do you think you need to be wearing that?
I'd say no for me.
Okay, Nadia?
For all aerosol, I would say yes, or FFP3 or equivalent, yeah.
Okay, Jeremy?
Yes from me.
Is that a yes from you now because of the height of the epidemic, because we're on it's still at level 4, and would you be happy if it drops down to level 2 to change your mind on that?
It's a yes, because we're in the middle of this, and I don't want to make changes from what we've started for a long time, so I get a feel for the effects of what we're doing.
Okay.
I'm very comfortable doing what I do once the rubber dam's on. And I'm not entirely sure once the dam is on that I'm at much risk at all, really.
That's a very different situation. Nadia,
and that's all I do, so.
Yeah. You prefer that, Nadia, is that because of where we are, or?
Yeah, and it's also, I think, following guidelines and following the advice that we have been given. And even if the sort of perceived risk without it is quite low, we have to protect staff, and we have to protect patients. At the end of the day, we want to be able to go in every day and see patients and treat. So, and you also know, with staff, you don't know who's living at home with vulnerable people, and so I think having that as a blanket for protection it's good for everyone all around, provided you can get it. Yeah.
Okay, so Len, I'm not going to ask you about this yet, because I'm going to save you up for a question further down the line, because I think I know what the answer is, because we spoke about this before. So can we have the poll for this one then, please? Okay. Okay, so people do want to do that. So there's a lot of people want to go along that route, and Len's giving me the wry smile, and I will also have a wry smile on this one too. Okay, So let's just go straight to the poll on this one. If we can't get FFP3s, then are you happy with the 6% reduction in risk with using FFP2s? I know you're desperate to say something, Nadia, so please do.
I was just going to say, yeah, I would.
Yeah. Okay. So I think the reason we're saying this is probably it's 6% reduction in risk of what. So if in London now we're down to 1 in 1,000 people are likely to be infected. If you look at that and you start to work out the risk analysis from that, then you start to see there's a very different level. That 6% is 6% of 1 in 1,000, which is a very small percentage. So I think we do have to be cautious about that. Now, the reason I sort of hadn't, we've got the poll for that one, haven't we? So the next bit is around fit testing, and I don't know how people have managed to deal with fit testing. Nadia, you mentioned
we have not had that done yet. We have a member of staff who's going to be on a fit testing course this week, hopefully. So we are hoping to do that. But yeah, I think a lot depends on that, on being able to be fit tested, checking that the staff that need it can fit it, and then the availability of it once we know that, and the continued availability of it as well going forward.
Okay, and Len, you've had some fit testing, I know, but there are issues around fit testing that we need to be concerned about, don't we?
Yeah, I mean, I think so it might seem odd that I'll say no to the FFP3 mask. It is the gold standard, and yes, you should achieve that. But I'm just conscious of the fact that they're not available. They're expensive, and then if you've got the FFP2 mask, when you talk about the actual difference in filtration, it's minimal. There's a marginal gain with an FFP3 mask, but you also talk about the other mitigating factors as well. These aren't just purely used on their own. You're using as part of an armamentarium of personal protective equipment, which is also the mitigating issues around rubber dam, around high volume suction, all of which we know high volume suction reduced by 81, 82%, rubber dam another 25, 30%. If you believe in mouthwashes maybe, but probably not. So it's not on its own. So I would be confident that the question is about the fit testing itself and whether you can actually wear an FFP3 mask, whether you can wear an FFP2 mask, and then the reusable ones. And so I've my own personal experience, having done it today, I was going to wear a stealth mask. We have stealth masks, and I was hoping to use them, but I couldn't wear them, not because I failed them, because I couldn't wear my loops. Yeah. So because the silicone over the bridge of your nose tipped up my loops, couldn't wear them, and so therefore I've ended up with an FFP2 mask, which I've passed and fit tested for. It's more expensive, obviously, but it is what it is. So what you're supposed to be, it's actually going to be the fit testing going to be adequate and suitable. So adequate is your FFP2 and FFP3 mask, but suitable is going to be suitable for you. And that's what your fit testers will do. Will test you to see whether that particular mask works for you in those particular circumstances with your particular PPE, your visor, your loops. If it doesn't work with you, they'll have to find something else.
Different makes are giving different results, and there are quite a lot of people at the hospital failing fit testing. So there is definitely an issue around that. So can we do the vote while we're doing this, and then Nadia, you talk as well?
Okay.
No, keep talking. Yeah.
All right, I was just going to ask a question about, so, provided you do a fit test and then you find that you're fit tested, it's suitable, so on, and then you can't get availability of it, and then you have to be fit tested again. What happens then?
Well, I think this is one of the big issues that we're facing. Even in the hospitals, we're not seeing the same product week in week. So I think that is a major problem. But there are also some problems with some of the fit testing. With the machine fit testing seems to have more people failing the fit testing than just the smell test one as well. So there's a bit of an issue around that, and that seems to be there are quite a few people who aren't confident that they're going to be able to get fit testing for their team there, that's pretty well 50-50, isn't it? It's not, there's not a big difference.
Vote of confidence.
Yeah.
Yeah, I mean, on that front, I've been fit tested 3 times on 3 separate types of the same manufacturer's mask as we went through them.
Yeah.
And you know, we're probably okay now with what we've got, but if we change the designer mask, then I'll have to go back and do it again.
Now, I don't think any of us will have the answer to this question, but the next bit is if people are confident what they're going to do if any of their members of staff fail the fit testing. I mean, obviously you can try different masks, but that's not that easy if it's difficult to get hold of the PPE. So maybe we'll do the poll and see what happens, and then we can maybe talk that through. It'd be interesting to see how many people have a plan B. Okay. So that's quite high. Perhaps we could ask the 2 general practitioners there. Have you got a plan? Have you got some ideas of what you would do?
I mean, for me, that's a really, really worrying statistic, the last question in this one, because if you're not confident of getting it or not confident about fit testing, we have a real problem going forward, because pretty well 80-90% of our dentistry is interventive, which requires AGPs. And whilst we can dream about having non-AGP, perio, endo, restorative, that's a long way away. So this creates a real access problem, because if practices haven't got fit testing, they therefore can't do AGPs confidently, they ain't going to be doing dentistry for some considerable period of time, and that creates a huge problem for access. It creates a huge problem for every sort of care around, and people have been waiting for the last 10 weeks for care, and they're waiting for interventive care. They don't want teeth taken out. They want the things that Jeremy can do, which actually save teeth. And if that's all we can do, because we can't do AGPs, we're actually no better than we were before we went back to work. So I'm very worried about this. And if you're thinking about policy and knocking on the doors of MPs, this is a big issue.
It is, yeah.
I guess a question for me, and I'm just throwing a question out there, being a GDP, we don't have all the evidence. The fit testing, my practice principals just sent me a message saying, why is this not an issue in Europe? Because they don't do fit testing there.
They don't, no.
At the end of the day, I mean, what were these masks designed for? Were the fit testing designed for infection control? And do we have evidence to show
asbestos?
Well, exactly, yeah. So
that's what they were designed for, removing asbestos.
If we don't have the evidence for what we're actually doing, we're holding off doing treatment for something that we don't even have any evidence for. It puts you in a really awkward situation. I guess back to what I was saying at the start. Why are we doing what we're doing? Are we doing it because we think that's the most sensible thing to do in terms of care for our patients? Or are we doing it because of litigation in society? Are we doing it because we're just following guidelines? Yeah. And I think we're all a little bit lost with it.
Yeah, Jeremy.
Well, yeah, Len pointed out that it's only one part of the multiple layers of protection, and of course, as with any test, you pass the fit test on the day you pass the fit test, but then you put in a mask on multiple times a day or multiple times in a week, and we don't know when we're using the mask whether we're getting the perceived benefit. So, I mean, the filtration should be standard for the mask itself, but the seal around the side is a functional thing. So it may just be a perception, and that over time we'll find that it's not either necessary because other people will use a lower level of protection, or that people using them will have problems because they don't work all the time.
It's really interesting. Is there any research going on from the UK in terms of anything actually of any benefit to us looking at this?
Well, the problem is, how are you going to do research? You're going to say we have to compare people we're not going to put masks on and people who are going to wear masks. So which dentist fancies doing that, and then have the research, because you're going to have controls. It'll be hundreds and hundreds of patients or thousands of practices in order to be able to do that sort of research. So it's kind of we've got a precautionary principle, which is where we're at the moment, and I think this may only last a few months, 5, 6 months. We know, as you say, they're not fit tested in Europe. The Europeans have been back to work sooner than we have. If it turns out that in the next 2, 3, 4 months there are no COVID episodes amongst dentists in Germany and Sweden and Spain and Italy, well, then people will say, well, what's the point? And guidance will change. I'm sure of it. And PHE will drop the idea of fit testing, et cetera, et cetera. But at the moment, it is the guidance, and we would be wise to follow it. But it doesn't solve the question. If you fail fit testing, what are you going to do? There are options. And you don't need to fit test your positive air respirator, the hood. So that could be worn. So lots of people who do, hygienists are using it. People with facial hair are using it. Not very effectively, because those are things quite difficult to wear. I've chatted to people who've worked in UDCs who've been wearing those hoods, and they are not easy to wear. It's all right for doing extractions or short interventions, but if you're doing root canal treatment or doing intricate work, they're impossible to wear. And if you've got loops, you've got lights on them, they'll reflect on the inside of them, so they're not easy to wear. There are alternatives, but they're not as good as. So I think we're all frustrated, but research is not going to happen, unfortunately.
So I think the next question is a bit naughty. It's really taking us to that next level and saying, right, okay, if we don't bother with that, why not just use a surgical mask? If a visor is so good, and if the visor gives so much protection, then will a surgical mask not actually be perfectly adequate? I've got to say that I personally think that will be okay.
Yeah,
there'll be a lot of people going, "Oh no, I'm going to die." But I've got to say that I'm fairly confident that will be fine.
Yeah, I mean, we've got to accept the visor is just for splatter. It's not going to stop your aerosol.
Yeah.
And if your surgical mask is not going to create the seal. So if your confidence as a practitioner comes from the seal, if you believe that the aerosol needs to be stopped by a seal around your face, you wouldn't put a surgical mask on, and you wouldn't rely on the visor. So it's a kind of your understanding of the process and your assessment of the risk. And I think we have to be really careful about this, because as dentists, self-employed people, self-employed associates or self-employed hygienists or therapists, whatever, that's all very well and good. The risk is to you, not to the patient, because the patient's got the COVID, they've got it, and you'll be it's your risk. When you've got staff, it's a different issue, because if you're an employer, you can't say, well, you know what, just wear the surgical mask, you'd be fine. That's the problem. And I think we've got to be really cautious about what you might think is okay for you. Is as an employer, you have a legal responsibility to make sure that they're working in a safe environment. And again, that's the challenge.
Nadia, if you want to join in, but can we do the poll at the same time so we can keep things moving?
I feel like my personal opinion is sort of with you, in the sense that I think long term this might be where it goes, but I don't know if it's quite there yet right now. Going back to what we were talking about before, about the evidence behind everything that we do. I mean, we could research, obviously not in vivo, but within a lab sort of environment, in terms of aerosol splatter and this very thing between the masks and the protective visor and so on. But where we're at now, we have to follow guidance, and I agree with you, Len. But long term, maybe this is how it will impact dentistry going forwards. Okay, so if we move to the next question, which is about sterilizing the FFP3 masks for reuse. Now, there's not a great deal of evidence on this, but there was something that's come from Stanford Medicine, and they investigated 3 disinfection methods. They looked at 3 different methods. One of them was using hot air at 75 degrees for 30 minutes.
One was using UV light for 30 minutes, and the other was using a steam sterilizer for 10 minutes. Now, not surprisingly, the steam sterilizer destroyed the mask and wasn't much use, so that's out the window. The UV light didn't do anything to the filtration, but they weren't convinced that actually the UV light went through the whole of the mask, so it didn't necessarily sterilize the whole of the mask, and they didn't do testing on that. They also looked at the hot air, and the hot air was good, but what they also didn't mention in this article is whether the hot air damages the seal around the mask. So if you're going to reuse it, whatever we're doing to it, you don't know whether that seal is going to be broken by whatever the sterilizing procedure. So I don't know whether people would feel comfortable, and we'll do the poll now, but we'll talk about it as we're doing it. Jeremy, what do you think about that?
Okay, so I mean, we chatted about this before. So whether or not it affects the filtration is one thing, and we could rely on, that'd be a pretty simple thing to test, wouldn't it? The seal is the other issue, and from my own personal experience, when we started, I had the mask given to me that I was going to be fit tested on, and then because we hadn't used it on a patient, the potential was that I could use it when we first started treating patients, because we were shepherding the supply at that time. Later, when I went back to fit testing on a different brand, of a different type of the same brand, the person that did the fit testing then answered me, was very unhappy at the idea that I would ever try and reuse the mask, because once the seal had been broken, the seal was broken. Now, go back to what we just said. The fact that we passed fit testing on day one doesn't mean that when we're using the mask, it is actually providing the seal that we think it is. But the reason I don't want to change from what I'm doing is precisely because we won't get any research on this. And I just want to see how long we can go without problems to get a feel for whether things are a problem. So I can't see that you know, if they can be autoclave, that's fine, but that's only part of the problem.
Well, autoclaving was the one that did destroy it, so that's definitely out. So it's going back to hot air ovens, which are probably
and
you might just remember from the old days, but that
I read
it'll be in the back of a cupboard somewhere.
I think this is, you know, there's going to be an issue with supply, but I'm not sure this is a solution to the issue with supply.
Yeah, Nadia, would you feel comfortable with reusing them? 3M, by the way, are a company that are recommending this. So one of the questions from the audience was about that, and they're saying that they're all single use. Actually, there are companies, 3M are one of them. There are other companies recommending that they have masks that can be reused.
I sort of agree with Jeremy. I mean, if sterilizing them is going to break the seal of the mask, and the whole point of using an FFP2 or FFP3 mask is seal, why are we doing it? If we don't have a seal, might as well use a surgical mask on a visor. So
I agree completely. Len, have you got a different view to that? Or?
I agree with that.
No. Okay. So one of the other things that has been recommended, let me just make sure that I can turn to the next bit, is covering an FFP2 mask with a normal surgical mask. Now, when we did the last webinar, this was mentioned because the OMFS people have been doing this. The worry is that if you've got the respirator at the front, then actually the issue is that you could possibly be dripping sweat or whatever through that, and then you need the other face mask to catch that so it doesn't drip all over the patient, and you're contaminating the patient, not the other way around. There were definitely a lot of people writing back saying that this is not something that we should be doing, and I just wondered if the audience have, one, any experience of this, and two, any view particularly on it. It doesn't seem sensible to me.
I sort of don't get it.
No, well, I don't either. That's good. That's two of us at least, Nadia.
I mean, no. I mean, we've not had a problem with supply. So, and then the idea was that if you had that extra mask on, the FFP3 was getting wetter quicker. It was just nonsense.
I mean, the two issues here are obviously I think one of the reasons for using an FFP3 with an exhalation valve is the fact that if you're COVID positive, you're breathing your COVID virus onto the patient. So that was the purpose of having the mask over it. The other issue is related to basically those people who can't fit test. So because for cultural, religious, or health reasons, they have facial hair. And so therefore, one of the options for them was you could use a positive air respirator. They're not very easy to find. They're certainly not in stock, and they're difficult to find. So one of the options, and it's one of what we put into our toolkit, to allow people, if it's an FFP2 and FFP3 not fit tested, because you won't have a seal around your beard, around your facial hair, and you wear a surgical mask over the top of it. Now, that is not a recommendation. That is an option as part of a risk assessment. The gold standard will be a fit tested FFP2 or FFP3 mask. If you have facial hair and you can't remove it or won't remove it and have a reason not to remove it, you don't have a seal. So you're either not going to work, or you're going to try and use the positive air respirator, which is very difficult to work with, doing intricate clinical dentistry. So you have an option. So this was an option, and it's certainly an option that people can consider. It's not going to create. You have to be sure. We know it's not going to. There won't be a seal, but it's part of a risk assessment. You may decide you're going to do it. So that would be that would be the situation where you may say, actually, I've done, or indeed you failed every fit testing. You failed every other fit testing process. You can't wear the other things. You can't get a hold of them. This is an option, and nobody's saying this is your first option. This may be your last ditch option in doing that, because otherwise you won't be able to work.
So we'll vote on this one. I suspect we probably know the answer, but let's just be absolutely sure that people. Yeah, okay, so that's pretty well everybody. We're certainly 2/3 of the people are thinking that. I've got to say that it does worry me, and I think we do need some more evidence, but I'm not quite sure, as Jeremy said, I'm not quite sure how we're going to get it unless he puts his hand up for us to try it out on him, which, no, he says no. Okay. He's no fun anymore. So we've got 3 questions here, which are just quick questions. I've put them in because people are talking about this. I have people in my hospital who want to wear double gloves. And I know, Jeremy, you've got a comment on that, so maybe you can talk that through in a second. The disposable shoe covers, my view is that if you're wearing wipeable shoes, you can wipe them with Clinell wipes. I think probably if anybody needs to wear disposable shoe covers, it's probably the patient, but we can talk about that. And surgical hats, whether there's any benefit from wearing a surgical hat. Nadia, I'm going to, because you've got long hair, I'm going to sort of put that one onto you. But if we can do the vote for that, you'll be able to vote for all 3 separate questions. And Jeremy, do you want to talk a little bit about your experience of double gloving? Yeah,
so just this last week and a bit, I've been practicing with double gloves because someone suggested I might end up having to double glove as part of the guidance. And 2 things. It's very challenging with an endodontic hand file to get the dexterity and grip that I'd be comfortable with. And actually getting them off is quite challenging, particularly since I'm using the same type of glove. They're the same color, they're the same size, and the idea, I suppose, is you take the dirtiest pair off and then you can do the rest of the doffing with a slightly cleaner pair. It might work better if they were different colors, but they're exactly the same glove, so they fit very closely. And it's been a real challenge getting them off, if I'm honest, without making the doffing process less efficient than it actually was already. We're quite clear about how to take the gloves off, pinch the one side inside the cuff on the other side. But when you've got 2 sets of cuffs, it's been a real issue. So I'm not a big fan.
Okay. Nadia, do you want to talk a little bit about your views on maybe wearing surgical hats?
I don't have an answer. If I was given one, I would wear it. Obviously, I do have long hair, and for work, you would keep it tied back, and away from. But as we've just discussed, if you're doing an aerosol generating procedure, then yes, you will have droplets in your hair, micro droplets that need to be washed. We used to have a shower in the practice. We don't anymore. So it would be a case of you wouldn't be able to do anything about it till you got home. But then also, I think I would do my own risk assessment on it. For example, how long is the exposure time of what I'm doing? Am I doing a very small adjusting the occlusion when I put temporary filling in which case, how much is in my hair? Or am I doing an access very deep caries? I'm going to be there for a very long time. And also, you properly triage the patient. So don't have an answer, but it is a question.
Yeah. And Len, so you've got the bad question really about the disposable shoe covers. do you have a view on?
I don't think there's any need to wear shoe covers. Basically, I think there's more hassle you putting your shoe covers on, taking it off. You're more likely to contaminate your hands and everything else. Unless you're going to be licking your shoes afterwards, I don't think there's any particular reason why you have them.
Yeah, well, I think we'll keep that for a different sort of video, and then but I don't think that's something we really want to be. We don't want to be thinking about. But I think it looks as though pretty well people are clear about that. There's a bit more influence about wearing surgical hats, and I think there's perhaps a little bit more work about what are suitable ones for people to be wearing as well. I think there are quite a lot of different things on the market. I know some of our Muslim ladies have wanted to wear the more what I would call like a balaclava type hat, and we've not actually seen one at the hospital yet, but I would like to see how effective those are for them to be able to wear, because I think that's going to be something important for them, because they don't want to be wearing their scarves and get their scarves infected. So I think that's something else that we need to be very aware of, especially with the issues around AME groups as well, which we have to be cognizant of. So thank you for that. So we're moving now to what is actually the last question, and I know we're overrunning a bit here, but thank you everybody for keeping on board, and especially Nadia, who has a little baby who will be desperate to see her any second. So if you can bear with us for one more question. And really it's more, are you clear about how much downtime you need between patients? Now, I think from the last webinar, I told you that there are 3 dental hospitals in the country that have got the proper 6 turnovers per hour. I think there are very few practices that probably have got that in place. So is everybody reasonably clear about what's happening with that? Len, do you want to start with how you're managing things in your practice?
Yeah, so I think we'll start with non-AGPs. It might be controversial, but it isn't in my mind. If you're non-AGPs, there's no downtime, there's no fallow time between patients. You just see the next patient, so you could potentially see back-to-back a non-AGP patient. So I'm not overly concerned about that. As far as the fallow time is concerned, so the PHE guidance is 60 minutes. It's what the FGDP have said as well, and they kind of said, if anybody is watching the webinar yesterday, Ian Mills says they were kind of encouraged to do that by PHE to come up with that particular position. But obviously but that's the sort of outer time. So but there are other mitigating things that reduce that. So depending on what you've got, you've got a window open, you've got ventilation, you've got air extraction units, you've got air filtration units. There's a whole lot of different things that will reduce it. But also, more importantly, which is why the faculty came up with the idea of aerosol generating exposure. It actually is about what exactly you're doing. It's not a binary thing of all AGPs are the same. They're not all the same. If you're doing 5 minutes of smoothing a tooth with a fast handpiece as compared to a full mouth ultrasonic debridement that you may do for 45 minutes, they're different things. And also the other thing that we just need to remember is that the fallow time starts when the AGP stops. So if you do an hour and a half you've got a patient booked for an hour and a half, and you spend the first 30 minutes opening up the tooth, you're doing root canal treatment, opening up the tooth, dismantling the restorative material, opening it up, and you spend the next hour or next hour basically finding the canals, as I do, and never find them. So I'll be sending them off to you, Jeremy. An hour later, still haven't found them. I've actually been sitting in my own fallow period, as it were. So actually, the period of time is 60 minutes. So technically, you might say that the fallow time is 0. It isn't, because it was still the 60 minutes. Yeah. So we've got to get our heads around what exactly we're measuring. It's not from the end of the appointment. It's actually from the time it's got an AGP. So that, I think that's an important point to get across.
Yeah. Okay, Nadia, have you anything to add to that particularly?
Well, we've started with non-AGPs, so exactly. Yeah. There's no time really.
Not really, and presume, I know Richard, I'm going to come to you at the end, but that will affect orthodontics if they're not regarded as non-AGPs. Then I presume that it's really just normal turnover between patients, isn't it? Really.
Well, it would be in terms of the non-AGP. I think we still obviously at the moment have to respect social distancing, so that will slow down the throughput of patients, because you're making sure that patients, for instance, don't cross over as they're coming in and out. So, so I think in terms of the procedure, yes, it's helpful, but it still won't be totally business as usual for most practices, because you're managing the patient throughput in terms of social distancing.
And one of the questions from the audience was about whether we should be giving patients surgical masks when they come in through the door and they're in the waiting room, which I'm fairly in favour of. I don't know what people think about that.
From that, Phil, I think it's not inappropriate to actually tell patients to get their own if they're travelling on the bus or the train or whatever.
Okay. There's two parts to that, though. So if they've come in on the train, and let's say in London they've come on the Underground or whatever, and then they arrive at the practice. Now, what we're doing at the London Hospital is we're going to ask people to take off those masks and gloves that they might have worn, put them into a bag, and we're going to give them a mask to sit in the waiting room, because we're worried about whether that mask is actually contaminated or not.
Okay. Well, from the 15th of June, Monday, you're going to have to wear them anyway. So anybody, well, you can't social distance. So, and again, that also applies to practices, trusts, but also practices. So your staff who are not wearing PPE would have to wear a mask as well. So if you are wandering through reception, you don't have screens. So social distancing is obviously the 2 meters, you have screens or whatever. But if you're walking through, a dentist walking through, they need to have a mask as well. So that's from June the 15th. The advice, the guidance just came out in the last 24 hours, basically 48 hours. So
yes, And Jeremy, you'll be very smug over this, because of course you'll have the thing that you've mentioned all evening, rubber dam on, and obviously this is something that we are recommending wherever possible. Is people, if they can put what one of my colleagues at the hospital calls advanced rubber dam. I think that just means you put it on properly. That would be a technique that people are going to have to spend some more time doing, and I think it's going to become more common, the use of rubber dam even for normal restorative procedures. That alongside high volume suction, which is sort of reducing aerosols, I think, by about 70 up to 90%, then I think your world is probably a little safer.
I think that the AGP's clearance time starts from the moment you finish the AGP. So in a long endo appointment, it's as then said, by the time you finish the endo, you may well have dealt with a fallow period. So that's where I am. Although currently in the emergency treatment, I'm finishing well before that, because I'm not doing root canal treatment. I'm just cutting an access cavity and either extirpating or dressing. So there is a clearance time, but there wouldn't be if I was completing the treatment.
So the last word, Nadia, I think it's, and let you get back to your baby. Have you a comment?
Well, no, just same as everyone else. I think we'll have to follow the guidelines as much as everybody else on this for the moment. I was listening to one of the webinars, I'm trying to think which one it was now, because I've heard that many, about why they chose the time of 1 hour. And, it was sort of an agreed time based on all it wasn't quite simple as this is the most effective thing that they had. So. That's quite interesting.
It's come from Public Health England, and it's to do with the rate of clearance in a room, and there are recommendations around that. And then the WHO, which was 2007, that's where the hour came from.
Yeah.
If you have a room that's completely still, then it's an hour. At the last webinar, and this almost sounds funny, but it really is not. It isn't amusing. One of the questions that I got asked afterwards, and I will try and answer people's questions that have been asking them, and we've not managed to cover them during the webinar. But one of them was, I work in a room where there are two windows, and if I open both of them at the same time, will the air blow through? Well, the answer is, depends how windy it is. But you can answer it in that way, but actually people have got problems. Another person who was at the webinar was saying, I work in a room that has no windows. So that is a very different situation. And then you've got whether you've got your air conditioning on, and then there's evidence. There are two bits of evidence around that. One is that as long as you've not got recircling air, that's okay. But if you've got your air conditioning on and you do have an aerosol, the problem is that of course you're blowing that aerosol around the room and you're spreading it. So potentially there are more issues around that. So I don't think we do have a specific answer, but perhaps we could do the poll just before we call it a day.
Yeah, I mean, when I looked at this earlier, I made notes, and my answer was yes. I'm very clear based on the guidance that we have. But as you just said, when you think about it, there's a lot to take into consideration.
Yeah. And I think that answers one of the questions that we've just had about air conditioning. I think different air conditioning provides different issues. So not an obvious answer, and I think people aren't convinced over how long they need between patients. And I think there's going to be a lot more discussion around that, and it will depend on what your practice is. And I think it goes back to something Len said a lot earlier. This is something to do with an SOP for your practice, and you've thought about it, and where there's been a risk. I think it's always a good advice to get someone else's eyes on those SOPs from elsewhere. If you can phone a friend, that would probably be a good idea, to get them to have a look at the SOP, because they might see something that you've missed. I don't know.
One thing I just want to add is the other thing is that we've been talking a lot about stuff that costs money. People have spent an awful lot of money on things that may or may not be necessary. There's a lot invested in this. Sometimes it's a bit of an arms race, as it were, between people saying, I've got the best people, and advertising in that way with all these air filtration, which is a bit of a shame. But more importantly, I think the answer is that everybody in the business is trying to make this as easy as possible, because the commissioners themselves will recognize for NHS services that if you have a fallow time of 60 minutes, that's kind of the end of your services. You can't deliver NHS care, you can't deliver private care, you can't deliver any care at 60-minute fallow period. The practices are going to be unviable, unsustainable. So the commissioners, everybody is investing a lot of time and energy and effort to get this right. Be safe, but also to make sure there's as pragmatic as possible, because so I think anybody's listening or anybody's concerned about it, these things are changing virtually on a weekly basis to make things easier and faster and quicker, but still being safe. And you can look across Europe, look across America, look across the world, and look at other people and thinking, okay, well, they're ahead of it. So why are we doing what we're doing? Is it evidence-based? It's not there's not a huge amount of evidence. We're doing it because we're being cautious. But everybody's invested to try and make this quicker and faster and get people back to work. The MPs are, the commissioners are, the practices are. So I think we should reassure ourselves that we haven't answered all the questions, but some of those questions will become answerable as we progress over the next weeks and months. Definitely not years. But
just a final reassurance before I ask Richard to close this evening is that the Royal College of Surgeons of Edinburgh have been working very hard on your behalf as far as this is concerned. One of the questions that we've been asking is whether the PPE requirement will come out of the GDS budget as it stands at the moment. And if so, how is that going to affect what you can and can't do on the National Health Service? If it is going to be extra money, when will that be available? And can we be absolutely clear about how that money is going to be dispersed into practice? And there will be issues about mixed practice, but that's for another time. So Richard, if you wouldn't mind, please, closing the meeting for us. Thank you.
Yes, well, on behalf of the college, thanks to everyone. Thanks to our IT support behind the scenes who we don't see, but Ryan, thank you for your support. Thanks to all the participants and also to the panel. We hope you found this informative. We will be aiming to answer any questions that we haven't asked during the session, and certainly please give us your feedback as to what else you feel we could do to support you in what are still very difficult times for the dental profession. Thanks to all.
Thank you.
Thank you. Good night, everybody.
Bye.